Hello, everybody, and welcome to ILAE's webinar on functional seizures in children. This is a webinar organised by the ILAE, the Psychiatric Task Force and the Pediatric Task Force of the ILAE. My name is Colin Reilly. I'm a psychologist working in Gothenburg in Sweden, Queen Sylvia's Children's Hospital, and also Young Epilepsy in the UK. Very excited to chair today's webinar, which we're going to go through, take you on a journey through functional seizures in children, focusing on neurobiology, treatment, looking at some recommendations, and also co-occurring psychiatric conditions. In terms of the Q&A, so if you have questions and answers, please write them in the Q&A box at the bottom of the screen, and we will address all questions at the end of the webinar, so not during the webinar. The webinar will also be available on ILAE's YouTube channel in the near future. The term functional seizures is used, but we acknowledge that functional seizures may also, dissociative seizures may also be used. So around the world, functional seizures may be used, functional dissociative seizures or dissociative seizures, but they all refer to the same phenomenon. We have three very distinguished speakers today, and our first speaker is Kasia Kozlowska from Australia. She's a child and adolescent psychiatrist and a clinician researcher at the Children's Hospital at Westmead and Westmead Institute of Medical Research at the University of Sydney. In her clinical role, she runs a multidisciplinary consultation liaison team, a research program for children with functional neurological disorder, and a specialist program called the Mind-Body Program for treatment of children disabled by functional neurological symptoms. And it's a great privilege to introduce Kasia. She has a great deal of experience in this area. Over to you, Kasia.
Thank you, Colin. So thank you for inviting me to talk about functional dissociative seizures in children and adolescents. And there's been major, now I can't move my slides down, so that's a problem. There we go.
Yeah, it's working now.
Yeah, thank you. So there's been major advances pertaining to the neurobiology that underpins functional seizures, and I will present key findings that are useful to keep in mind to help with treatment planning. So, key point 1, children with functional seizures have increased autonomic arousal. In healthy children, the autonomic system activates in response to a challenge and then it settles down. But in children with FND and functional seizures, it stays activated. And here you can see the metrics from some group data. Children with FND, including functional seizures, have increased heart rate, lower heart rate variability, and increased skin conductance as compared to age and sex-matched controls. So key point 2, children with functional seizures have increased brain arousal. So for example, in this EEG study, you can see that children with functional seizures have higher gamma wave power, so higher brain arousal than those with other FND symptoms and higher than healthy controls, which is the blue line. And gamma power in this study correlated with arousal in the body, lower heart rate variability. So why is this important? Because the way the brain organizes with normal arousal and safety and the way it organizes with high arousal and danger is different. In states of high arousal or danger, limbic and motor sensory processes are prioritized over those involving the prefrontal cortex. So keep this in mind. When arousal increases in the body, it also increases in the brain. So key point 3, many children trigger their functional seizures by hyperventilation. When the autonomic system activates, the respiratory motor system can activate alongside. And here you can see a study of hyperventilation and EEG power bands in children with functional seizures, the top picture, and healthy controls, bottom picture. You see an increase of EEG power, brain arousal in both groups in response to hyperventilation, because hyperventilation increases cortical arousal. But when the hyperventilation ceases, healthy controls go back to baseline and the brain arousal in children with functional seizures stays elevated. Look at the yellow line showing the beta power band. And this is lovely data from Canada. So key point 4, children with FND, that FND, including functional seizures, is a disorder of neural network dysregulation. So in this study, we examined neural networks using independent component analysis in mixed FND and healthy controls. And here you see 8 networks that we identified in the whole group, FND and controls. And in children with FND, we found differences within and between all 8 networks. The red color marks networks with increased connectivity, and the purple color marks networks with decreased connectivity. And an interesting finding from this study was that subjective distress, total DAS score, and autonomic arousal, indexed by resting state heart rate, contributed to the modulation of neural networks, the aberrant changes that we found. So the higher your arousal and the higher your distress, the more marked the dysregulation in your neural networks with FND. And in the networks that I circled, the frontoparietal and dorsal attentional networks, children with functional seizures showed a more marked change, greater connectivity decreases. So in picture form, what we're seeing is a disconnection between frontal regions and other regions in the brain. So this study really highlights that we can think about pediatric FND and functional seizures as a disorder of brain networks. And in fact, this is the sort of language that we use in our recently developed fact sheet. And here you see that functional seizures that are described as a sudden, time-limited episodes of brain network dysregulation. So key point 5, functional seizures are underpinned by disconnection, dissociation between brain networks. So some French researchers used stereotactic electrodes, so electrodes implanted in the brain, to measure connectivity between brain regions at rest, during an epileptic seizure, and during a functional seizure. The patients were being worked up for epilepsy surgery. Both patients in the study, one aged 19 and one aged 37, suffered from childhood onset drug-resistant epilepsy comorbid with functional seizures. The younger patient had a history of physical and psychological abuse at home, and the older had emigrated to France during the Kosovo War in 1999. And this visual representation shows you the pattern of connectivity in epileptic seizures, the blue and green, and the pattern of connectivity in functional seizures, the red and orange. In epileptic seizures, connectivity is increased, and in functional seizures, connectivity is decreased. And in this visual representation, you see the loss of connectivity between brain regions in both patients during a functional seizure. Lines that are coloured from orange to blue mark decreases in connectivity, with dark blue representing the most decreased and orange-yellow representing the least decrease. Overall, the representation shows that the most important decrease in connectivity affects the relationship between the anterior insular and parietal cortices. So again, we have the same theme emerging, a loss of connectivity between cortical to cortical regions. And we see the same pattern of findings in EEG studies, a loss of cortical to cortical connectivity and a loss of cortical to subcortical connectivity. And when we recently looked at neurometabolites in this study, we likewise found the same pattern of finding, a loss of conditional dependency between metabolites in frontal regions to metabolites in the SMA and posterior regions, the precuneus in this case, in the subgroup of patients with functional seizures. So key point 6, illness-promoting psychological processes play a role in the illness process. So in a study of 76 children with FND, including functional seizures, the most common illness-promoting psychological processes pertain to the following domains: attentional processes, so attention to symptoms, cognitive processes, negative catastrophic symptom expectation, cognitive process such as self-critical rumination, feeling-related processes, feeling worried about schoolwork, friendships, or parental well-being, avoidance processes, pushing difficult thoughts out of mind, pushing difficult feelings out of mind, and avoiding activities, disconnecting from the body, and unresolved loss, unresolved trauma, and unresolved bad experiences. So it's really important to remember that psychological processes have a top-down effect on the stress system. Illness-promoting cognitions will activate the stress system, the red, and calming cognitions will down-regulate the stress system. So key point 7, children with FND and functional seizures have higher adverse childhood experiences. Physical stresses such as viral illness, injury, or medical procedures are as common as psychological or relational stressors. They also have higher levels of distress. So here's the neurobiology in a nutshell. We have adverse childhood experiences. We have increased autonomic arousal, increased cortical arousal, neural network dysregulation modulated by arousal in part, and illness-promoting psychological processes. And this is our visual representation of the same thing. It tries to capture the elements of the proposed etiology, again, adverse childhood experiences, their role on stress system activation and psychological processes, plasticity changes mediated by epigenetic changes and glucocorticoids, resulting in changed neural networks and an increased vulnerability to functional seizures. And then this is a much more detailed figure trying to capture the complexity of the proposed etiology process. But of course, when you're talking to children and families, you want to keep it simple. You want to use simple images that capture the neuroscience and that provide you with a rationale for treatment. So I'm going to share some that we typically use with families. And if you want any of these images, you can get any of them from these resources. They're open access, they're free, and you should be able to download them. So this visual representation depicts the stress system. And it's particularly helpful when functional seizures are triggered by a physical illness, or when there's other functional somatic symptoms involving multiple components of the stress system. So here we see a functional seizure presentation that was triggered by an infection, a meningitis infection, and our picture helps the family understand that the infection activates the immune inflammatory system, which interacts with all other components of the stress system and can activate them in turn, thereby making the child vulnerable to functional seizures, even though the infection is now resolved. And this metaphor is particularly useful for functional seizures that present with a motor component. So this metaphor shows activation of the brain stress systems. The idea is that when the red ball becomes too big and too strong, it interferes with motor function and functional seizures can emerge. And rationale for treatment: to treat functional seizures, we need to decrease the size of the red ball, we need to decrease arousal, and in practice, this means that we use regulation strategies to downregulate arousal so that the child can control the functional seizures. We address the factors that activate and enlarge the red ball, for example, comorbid anxiety or depression, addressing unhelpful thoughts such as catastrophizing or rumination, addressing family conflict, bullying, addressing academic expectations that are beyond the child's actual academic capacity. We use adjunct medication to help decrease arousal, and we use therapy and adjunct medication to treat anxiety, depression, and PTSD. So I'm just going to put in a plug for pleasurable daily exercise, because I'm going to talk about regulation strategies, both top down and bottom up. But here I want to just point out that daily pleasurable exercise as a regulation strategy is an important one that modulates neural networks and various components of the stress system. And clinicians working in health forget the power of pleasurable exercise as a daily regulation strategy. And this slide summarizes the benefits of daily pleasurable exercise. So the majority of our patients with functional seizures haven't been exercising, as everyone is too worried about functional seizure events and falls. They are therefore deconditioned, and the deconditioning contributes to the propensity for functional seizures. So in this context, every child who's treated in the Mind-Body program does daily physiotherapy and is discharged with an exercise program as one of the regulation strategies that they take home with them. So this metaphor is helpful with functional seizures that present as unresponsive episodes, faint-like episodes, changes in consciousness, collapses, or mixed presentations. And in this metaphor, the cortex becomes overwhelmed and goes offline, control is lost over other parts of the brain, functional seizures emerge. And this metaphor is also helpful, a sort of helpful summary of all the studies which show that functional seizures reflect a disconnection or dissociation between brain systems. And of course, dissociation is a survival strategy to help the individual manage intolerable events or memories. And the rationale for treatment: we use regulation strategies that increase pleasurable interoceptive and sensory input to signal to the brain that all is well or all is safe. The brain need no longer disconnect but can come back online. We sometimes use jarring smells like smelling salts to bring the brain back online, and we need to treat the underlying issue, whatever it is for that particular child. And this is the pressure cooker metaphor, and it's one that adult patients seem to like in particular. So this slide highlights that the intervention for functional seizures is part of a broader biopsychosocial assessment intervention. And the part in yellow at the very bottom is the intervention for functional seizures themselves. Step 3 and 4 are very important. They yield a formulation which gives you an overarching view of the patient's presentation. The formulation informs your treatment interventions, all the interventions that are needed to help the patient on an individual level, family level, and school system level, and so on. So this is an example of a very simple formulation: mild anxiety and academic stress. The treatment will be straightforward. The treatment of anxiety using CBT, and intervention that sets a more appropriate level of academic expectation, as well as the intervention for functional seizures. This is a more complex formulation. There's ongoing family stress, ongoing bullying, anxiety and depression, and illness-promoting psychological processes that will need to be addressed. Here you'll need to treat comorbid anxiety and depression, address bullying with the school, and run a family intervention, as well as addressing the functional seizures. And this is a very complex formulation. Here you'll also have to manage significant mental health issues, and at some point in time, the child may need to engage in a trauma processing intervention. And you also have comorbid pain, which complicates your presentation. And this intervention is likely to be longer term, to run for months or years. So now I'm going to run through the 5-step plan we use for managing the functional seizures themselves. And this visual representation also includes the instructions for the parent or supporting adult. So step 1, identify the warning signs of a functional seizure. So the capacity to identify changes in one's physiological state is a bottom-up mindfulness skill, a skill of interoception. Functional seizures are preceded by a state of activation, physiological activation in the body, and neurophysiological activation in the brain. And most patients are able to build the capacity to notice the changes in their body state that precede a functional seizure. So this slide lists some of the common warning signs, and you'll notice that warning signs reflect activation of the pain system, the autonomic nervous system, or the respiratory motor system, that is, symptoms of hyperventilation. And our team likes to use non-verbal tools, the body map, to explore changes in physiological state of the body. So here's a body map drawn by a young woman to depict her state of activation prior to a functional seizure on the left, and a state of greater calm on the right after the use of regulation strategies. And here's an artwork by another adolescent in a more abstract form, the state of activation in red and a state of greater calm in blue. And later on, you'll also identify any environmental triggers, emotions, images, and thought patterns that are part of the sequence of activation. Now, this looks easy, but sometimes it's not. And some children take time to develop these skills, and it can be a lot of work. And if you have been sexually abused, for example, you may try and avoid noticing and tracking changes in body state. Some physiological states may function as triggers for trauma-related memories. So step 2, make yourself safe. We want to avoid injuries, and we want to manage fear of falling and so on by ensuring the child is safe. So in this step, we shift focus of attention from the symptoms, reading our body state, to the action of making oneself safe. We practice this action with the kids so it becomes known and automatic. Some patients have a small window, less than a minute, from the time they notice their warning signs to when they have a functional seizure. So they need to act very quickly. They need to adopt a safe position the moment they sense the warning signs of a functional seizure. Step 3, implement a mind-body regulation strategy to calm your body and brain. In this step, the focus of attention shifts to the implementation of a regulation strategy. This shift of focus of attention away from the symptoms is really important. Remember, attention to symptoms makes them worse. If the patient continues to focus on the warning symptoms, she will amplify them by unhelpful thoughts, and the functional seizure will occur. If the patient focuses away from the warning symptoms and engages in regulation strategies, calms the brain, body, and mind, the functional seizure will not occur. So the regulation strategies are being used to shift body and brain state from an activated, dysregulated, out of control state that is compatible with functional seizures to a calm, regulated, I am in control state that is incompatible with functional seizures. And you start building the patient's toolbox with one strategy, and then you add strategies to the toolbox. You can use bottom-up strategies, those that involve the body, or top-down strategies, those that involve the mind. For bottom-up strategies, you can use slow-paced breathing, grounding strategies, movement strategies, passing a ball from hand to hand, moving in synchrony with music, or habit reversal as used by Aaron Fobian, movements that are opposite of the functional movements. Moving arms, legs, rolling the head. And many children like sensory strategies, smells, tastes, music, and a very strong stimulus is also helpful sometimes. You and the patient practice these and keep what is most effective. You can also add top-down strategies, calming imagery, imagery that manages pain, if pain triggers the functional seizure, self-talk that is empowering to replace unhelpful thinking patterns, I can do this, I have a plan, I know what to do, and so on. And when the patient succeeds in averting the functional seizure, it's really important to celebrate the success. In our team, we typically use positive suggestions to state that the patient's skills will improve more and more as they practice, and that their ability to avert the functional seizures will become more and more stronger and stronger, better and better. You are building mastery, you're building their sense of increased control. Step 4, write it out. For instances that the patient does not manage to avert the functional seizure, we ask them to write it out. And in Australia, we use the metaphor of surfing the wave. The process of surfing the wave includes being dumped by the wave, battered about by the wave. One emerges from this process unscathed and tries again. Ditto for functional seizures. Some calming self-talk can help here. I know I'm safe, I've done it before, I'm riding the wave, and so on. Step 5, implement a mind-body regulation strategy once the functional seizure is over to calm the body and brain. And your goal here is to use strategies that decrease the patient's state of activation, create cues of safety, and that provide a sense of mastery that the patient is in control. And you want to do all these things so that the patient does not fall back into another functional seizure. In an adult group who completed the program in Edinburgh, this is the step they found the hardest. They all wanted to rush to the next thing. And what they needed to do was to calm their body and brain, to slow down, to regulate. And then the patient keeps working on the 5-step plan. This is a functional seizure traffic light safety plan. It's a simpler version that we use with younger children. Green zone, all's going well. Orange zone, the body is starting to activate. They have warning signs of activation and need to use their regulation strategies to calm their body and mind. Red zone, they're having a functional seizure. And finally, what do you do with seizures that go on and on and on? Prolonged functional seizures over an hour are quite common in children and adolescents. So make sure the patient is safe, stay calm and keep the environment calm and quiet. Insert an earpiece with a favourite piece of music, hopefully chosen by the patient as part of the treatment plan to help the brain calm down. If the functional seizure is very long, we use a stat dose of medication to help downregulate arousal. For example, an olanzapine wafer that is placed on the tongue, it dissolves and is swallowed with saliva. And when the patient emerges from the functional seizure, implement a regulation strategy. And then keep working on the 5-step treatment plan until the patient can avert some or all of the functional seizures. Implement the rest of your holistic assessment treatment interventions that are part of your treatment plan. And once the functional seizure plan is in place and is being implemented and practiced, you need to get on with the rest of the treatment. So here is the traffic light plan again. Here we zoom in on the red traffic light. And you can see that for this child, we're using PRN, pro-Renata as needed medication during the functional seizure, if it continues for more than half an hour. This is a paper that's just coming out about the use of adjunct medication. So it's in proof stage and should be out in about a week or two. So this slide summarises our use of adjunct medication in kids. We have 3 uses. So use 1, we use medications by regular daily dosing to downregulate background arousal to decrease the likelihood of a functional seizure occurring. Use 2, we use medications PRN, pro-Renata as needed before a functional seizure, during a functional seizure, or after the functional seizure, in cases where the child is really struggling to use their regulation strategies. And use 3, we use medications to treat comorbid conditions, anxiety, depression, PTSD, functional constipation, deficiencies such as iron, B12, vitamin D, and so on, which are actually quite common in our population. So use 1, using medication by regular dosing to downregulate background arousal. So our children with functional seizures have increased arousal. Their arousal levels activate outside of the window of tolerance, the blue level, into the red level. And in the red zone, they're much more likely to have a functional seizure. So regular medication that decreases arousal can help the child stay in the blue zone and can support the child to practice her regulation strategies and succeed with them. So these are the things we most commonly use. Clonidine, an alpha-2 agonist, has a short half-life and needs dosing multiple times a day. Guanfacine, an alpha-2A agonist, has a long half-life and is dosed once a day. And quetiapine is an atypical antipsychotic, and sometimes we use tiny doses across the day. Your use of quetiapine is usually short-term due to metabolic side effects. So use 2, PRN, pro-Renata medications as needed when the child is struggling to use their regulation strategies, when the child feels the functional seizure to be coming, or even during a functional seizure. So olanzapine wafer is the simplest to use because you can pop it inside the cheek. It dissolves and can help the child's arousal decrease and scaffold the child to use his or her regulation strategies. If the child's able to swallow, clonidines an option. If they're able to swallow, quetiapine's an option. Risperidone liquid is an option. And again, we're trying to bring down arousal so that the child can use his or her regulation strategies. And then again, we're trying to bring them out of that red zone into the window of tolerance. And use 3, which I've already discussed before, is use of medication for other comorbid conditions. So that is it for me. So thank you for your attention. I will stop sharing.
Thank you very much, Kasia. That was a great tour de force from neurobiology to formulation to treatment. So really interesting and a great start to the webinar. Just to say, we've had a question regarding whether or not the webinar is recorded. It is being recorded and it will be available on the ILAE YouTube channel in a short period of time. So that will be available as well if you want to view the webinar in the future. My next speaker is Kette Valente. She's Professor of Pediatric Neurology at the University of Sao Paulo Medical School. She's an expert on neurobehavior in children with epilepsy and has also published widely on neurobehavior, but also on functional seizures. She's very active in the ILAE and she's currently the chair of the Pediatric Commission of the ILAE. So over to you, Kette.
Good morning or good day. Good afternoon, I don't know. Good day, everyone. And it's a pleasure to be here to address the expert-based consensus recommendations for assessment of functional seizures or functional dissociative seizures in children. I'll break down this lecture in two. I will try to provide what I think it's important. First, the expert-based consensus recommendations for assessment. I will not touch diagnosis because we have treatment because we have 2 experts here, or 3. And then from the pediatric neurologist perspective, the key challenges that we may face, our healthcare professionals may face during evaluation, during the diagnosis. So this expert-based consensus recommendations was led by our chair, Colin Reilly, and we had a scope review, and I think I tried to portray Colin during the process in our meetings. It was, I think I got close because we are the first group conducting scoping and systematic reviews to achieve consensus and try to make guidelines. That's not possible with the level of evidence that we have. And after the final revision of 77 studies, it was complemented by 2 rounds of a Delphi process that was very strict, allowing just recommendations based on 8% of agreement or more. So something that we obtained from the scoping review is that the mean age of diagnosis based on 56 studies was during adolescence, more than children, so 13 years of age. And there was a predominance of females 3 per 1, or girls more than boys. A question that's, for me, not part of the scoping review, hard to answer, is about sex or gender balance, if we have these results because of the age, the mean age of these studies, because in children, we may not have these discrepancies. Usually it's 1/1, but just a question. Regarding the clinical characteristics that we could obtain from the scoping review, we have a pooled mean age at onset of almost 13. So the delay for diagnosis is, or the duration until the diagnosis in general 1 year, which is much less than adults when we speak about 3 to 8 years. And the median percentage of children with functional seizures who had epilepsy was 26%. Here we may have a bias because most of these studies are conducted in tertiary care centers, and in outpatient facilities in general is a little bit less. So I would say that there is a range here from 10 to 30. Why it is important to know all these characteristics and these demographics? Because most of, or at least the first step of your diagnosis, of your assessment, is based on the fact that you know this patient. You have to know the history, you have to know the age, you have to know the most common characteristics. Otherwise, you cannot. It's pointless to have a comprehensive assessment, a comprehensive history, if you know nothing about these patients. Based on the scoping review that identified 23 studies that included a description of what was called at that time psychogenic non-epileptic seizures and now functional seizures. There was no homogeneity regarding description, classification system, or the method of assessment. Most of them are based on video EEG, but there are some based on clinical observation. The classification system, we have different classification systems such as Griffiths and Everidity. Everidity is the most frequently used, but they were not validated, and they are based on the definition and the classification of seizures properly. So it's impossible to make a recommendation based on these heterogeneous studies, but a recommendation based on expert opinion was done, and the process of assessment for children with suspected functional seizures should include a comprehensive description of the episodes and events. And the sources of information should include the child, if the child is able to report, caregivers, and, if possible, a school report, since some of these children will have these events only in one place, mainly in school. Other factors that are part of these recommendations, we have 22 recommendations, and about assessment, we have, I think that 11 or 12, I don't remember. And it's about this process and what should be included. Also, a comprehensive medical and developmental history, like medical conditions, learning, behavior difficulties, schooling, because they are considered like risk factors. Potential stressors. It's important to remember that although we don't have studies enough to provide a recommendation in this sense, or to provide a statement in this sense, let's just remember that children are not like adults, and the stressors may not be the same. Actually, they are not the same. Like the school and academic difficulties play a major role, especially in adolescence. Family difficulties are important throughout life in children and adolescents. We're always thinking about bullying as a school factor, and indeed it is, but there are other issues. So don't think only when we speak about academic difficulties in children that struggle with ADHD or learning disabilities, but also in gifted children that face their first difficulties at school. So it's not restricted to one group or the other. Previous history of physical or sexual abuse may occur. Psychological abuse is super powerful, remember that, and any type of trauma. It's just as very hard sometimes to define what is trauma. Trauma is an individualized experience. What is trauma for you is not trauma for me, but anyway. And although also we don't have evidence enough to say that we should assess other functional symptoms or functional neurological disorders based on expert opinion, we should. Indeed, some of our children have more symptoms, like they go more often to infirmary, they have more pain symptoms, nausea, they get sick more often, migrating pain in different regions. And I think that Kasia provided a very good explanation for this. The diagnosis, based on the scoping review and based on expert opinion, we have an agreement that video EEG is the most commonly used method of assessment, and also the best, is the gold standard method for these children. And we will provide with video EEG the documented diagnosis, which is great. However, the task force was aware that video EEG is not available everywhere. In addition, even in high and upper middle income countries, when we have video EEG, it may not be necessary. And also video EEG is usually overloaded with surgical cases. So this is the gold standard, but still have some pitfalls. Is not everything solved only because you have a video EEG. But if you do, great. Home and video recordings, they are very important for a probable diagnosis. Why probable diagnosis? Most of the major motor events, when they present, it's possible to make a diagnosis if you have a home recording. You cannot rule out epilepsy if there is functional seizures and epilepsy at the same time, because you are recording just one event. Just remember that. So it's useful to confirm always, even during video EEG, if that type of episode or event is the event that that child presents. Because under stress, even during video EEG, they may present different events that are not the events that they have at home. That's why we do not advise, it's not a recommendation to use provocative techniques. Provocative techniques, first of all, we have to lie to patients. I'm not speaking about hyperventilation or photic stimulation that are part of the exam, but induction of seizures. And sometimes we'll induce one type of thing that's not the functional seizures that they have in their environment, that they have at school, that they have at home, or even they will have panic attacks, because it's very stressful. Even the video EEG, under certain circumstances, when you don't know your diagnosis, may be quite stressful. We'll have some levels of certainty for the diagnosis, and this was not created by our task force. It was previously done by the task force of, at that time, was psychogenic non-epileptic seizures, now would be functional seizures, about the possible, probable, documented and clinically established diagnosis. And that's why when I was addressing the diagnosis, I mentioned documented, I mentioned probable and possible. And then for possible, history is everything. So even the results from the scoping review showing the imbalance in sex, the age, that's the most common, the need of a detailed semiology and stressors and risk factors are needed to delineate, to provide a possible diagnosis of functional seizures. Looking at the levels of diagnostic certainty, we realize that there are two factors that are extremely important. History. History is the first step for everything. So again, we have to know these patients for possible, for probable, for clinically established and documented diagnosis. And it's also important the EEG. The EEG because we expect not to have interictal epileptiform discharge and during interictal, and then we also expect not to have ictal discharges. And it seems simple, but it's not. It should be, but it's not. So this is the second part of this presentation because those are the recommendations. But as a clinician, you may face some difficulties that we cannot cover with recommendations based on consensus or even based on evidence. And you should be aware of that. First, semiology. We didn't have enough to provide a narrative synthesis about semiology because, as I mentioned before, they were named in different ways, assessed in different ways, not following a proper classification because we don't have one. And we are using classifications that were created for adults, for children, which is not perfect. But this is a major gap that was identified, but still we have to mention. This is not part of the recommendation. This is part of what I consider that you must know, and that you must know to provide a reasonable diagnosis, a reasonable suspect diagnosis. First of all, this is the classical example that children are not little adults. And some of these signs and symptoms that we see in functional seizure in adults may not happen in children, especially in children, young children. They appear later in adolescence. They are, even in adults, red flags, not confirmatory, but what we see in children, and some of the best studies that we have, is that we have more minor motor symptoms than major, that classical thing that you have in mind. If you have an overrepresentation of young children, not adolescents, this is what we have. And this was demonstrated by Hema Patel some years ago, many years ago, when she classified or categorized her group in younger than 13 and older than 13. So you have more motor activity in those that are older than 13, but not in those that are younger, especially in the youngest group, like 8, 7 years of age. Just be careful then, because you may not have such a robust event, I would say. When our group compared younger than 18 and older than 18 in a larger series, what we observed is that major motor was indeed occurred more often in those that were older, young adults. And some of the classical signs, such as ictal eye closure, long-lasting phenomenon, post-ictal speech change, pelvic thrusting that we always expected we don't see, opisthotonus we don't see, and this intense vocalization during major motor we also don't see in younger children. Regarding EEG, video EEG, and ancillary exams, when we are discussing about the speakers, Colin told me I would like you to speak about EEG and video EEG, and I hope not to disappoint him. EEG and video EEG are major pitfalls, especially because clinicians rely completely on EEG and video EEG, and it's not that easy. It depends a lot on the expertise, on the experience of the person who is providing these reports. Okay, so in our recommendation, stretching a little bit, it's already been said, video EEG should be used in all children or in those that have doubts, but also with a clinician experienced in the diagnosis of seizure disorders. And why? Okay. The EEG has a lot of false positives. We have a group of things called normal variants, and some of them are very, very sharp. They are even spike. Look at here or here. So it's very hard to distinguish from sharp waves if you don't have experience and if you don't know the state. For example, in this case, it occurs more often during drowsiness. There are other sharp components too that may make things a little bit harder, such as 14.6, and you see how spiky it is. Isreda is a rhythm that we see in the elderly. It was in the past called subclinical epileptiform seizures, but it's not, and wicked spikes. And to identify them and distinguish from seizures or interictal epileptiform discharge, it requires a certain level of experience. Another abnormality that should not be important, it's not an abnormality, something common in children, is this low posterior dominant rhythm that's called youth waves, or hypnopompic and hypnagogic hypersynchrony. This is excessive slow waves that you see until the age of 12 during drowsiness or during awake. And it seems that is not important because it's background abnormality, but in a child, in a family that's trying to distinguish or trying to understand what this child has, when you have an abnormal EEG, an EEG with abnormalities, and they cannot understand the context, and if this is validated by the clinician that does not understand EEGs but believes in the report, then it will be a nightmare to treat later. Another possible complication for the diagnosis is the presence of a real epileptiform discharge. That does not mean epilepsy. The prevalence of epileptiform discharge ranges from 0.8 to 18.6. It depends on your sample. Children with mental disorders, I don't like the term, but anyway, it's what is used, but we have more epileptiform discharge in children with autism than we have in the average population. And age is a major factor as well. In children and young children, we may have almost 6.5%. So be careful with the EEG. Epileptiform discharge are not epilepsy. But again, in a child that have functional events, it's complicated. In a longitudinal study conducted in Modena, and I consider this the best study about epileptiform discharge and epilepsy, we have a population studied with 3,700 children from 6 to 13, and we have 3.5% with epileptiform discharges, not background abnormality, real epileptiform discharges. In a follow-up of 8 to 9 years, what we have is that only 5% had epilepsy, usually idiopathic generalized epilepsy that is associated with certain patterns that are easy to recognize. A common mistake that we have in the EEG is the presence of central temporal discharge. The same central temporal discharge, epileptiform discharge that we see in selects, previously called Rolandic epilepsy, and seems to represent actually a pattern of maturation, a maturational pattern. So it may represent, and it does, and although it's focal and may have your attention, in a child without epilepsy does not mean anything. It's a common thing, actually, as an unspecific finding. Be careful. But then we have video EEG, and our problems are solved, and everything is easy, right? Actually, no, it's wrong. Let's remember about focal seizures without loss of consciousness. Some of these children, even with epilepsy, they have only symptoms. They may complain about pain. They may complain about a feeling that's an epigastric feeling that we have in temporal lobe or a cognitive thing. And we have several studies showing that focal seizures without loss of consciousness, that in the past we called simple partial seizures, they don't have, in most cases, an EEG correlation. Only 18% will have, during video EEG, an ictal EEG change, meaning the EEG is normal, although we can see that the child is pushing button or referring something, and it will occur mainly in non-motor seizures. It occurs also in motor, but mainly in non-motor seizures, regardless duration. It's not only in brief episodes, but in long episodes. So there is a no ictal change. Only 15% may present some epileptiform discharge, not exactly an ictal build-up as expected. So a normal EEG, during video EEG, even when you are recording the events and seeing the child, does not mean that that child does not have epilepsy when you have this type of seizure. How can I make a differential diagnosis? Usually, it is associated with other seizure types. So if you just recorded this type of seizure, be careful that you need a prolonged monitoring and you need others. So they usually evolve, if they have epilepsy, to focal seizures with loss of consciousness, or sometimes evolving to bilateral tonic-clonic seizures. Something to be careful too, some of these children may have epilepsy and functional seizures. And when they have these symptoms, when they feel something that's part of the epilepsy, part of the epileptic seizure, they may evolve also with functional seizures. So you may have them combined. Another possibility for false negative is when you have a lesion causing a mass destruction, a massive destruction like this. Then you don't have what's called volume conductor. This is a real seizure, but what you can see here is just muscle artifacts. Maybe there are some slow waves here, but there is some slow waves during the EEG tracing. And you may think that children like this will not have functional seizures, but they may have both. So be careful. Another important aspect is the EEG recording obscured by artifacts. This is usually not considered important, but it is. In this EEG recording, we have a lot of artifacts, blinking, and muscle. And this is about functional seizures. We have here a functional seizure that was recorded. Here, another one, a functional seizure. And based on what I see here, I can see muscle, and also there is some movement. So I almost can see the seizure occurring, but it's a functional seizure. I don't see the activity, but it's hard to say that it's possible to see. But it's not the same with real seizures, right? In most cases, it's not. But let's see a frontal lobe seizure. This is a frontal lobe seizure. Then what do you see here? I see muscle, nothing else. If there is an abnormality under this muscle, I cannot see. I can see something here, and I can see an attenuation and some epileptiform rhythmic discharge here. So I would suspect, and based on semiology, that's a frontal lobe seizure. But during the moment that I would like to see, you can see how hard it is. And we'll have a special group that I mentioned before, is about those that are in the scoping review conducted by Colin, with 26% having both functional and epilepsy. We don't have any specific type of epilepsy that predisposes more often to functional seizure. It's not about that. You may have structural lesions or idiopathic. It's not about this. It's about the child, not about the seizure type at all. Just be careful in video EEGs for this type of child. Remember that during video EEG, the first events are usually the non-epileptic events, the functional events. They are under stress. There you have more functional events. It does not exclude the presence of functional seizures. So it's important to invite the parents to see and to check if this is the only event that your child has. This process is important to check if you need more time recording, and also for parents that children have both, so they are able to see both events and learn how to distinguish them on daily basis, because this is something that you need, their constant feedback. We think that we have pitfalls only in EEG or video EEG, but it's not true. Even in MRI, so not always you have a normal MRI. You may have, for example, cysts, like embryonic cysts that have no meaning whatsoever, and also some enlarged perivascular spaces, in this case in the left temporal lobe, and it mimics, for example, a dysembryoblastic tumor that has this cystic appearance. And if you have an EEG in some of these patients, you may have some slow waves in this region. So you have to consider everything, but everything inserted in a context. And after analyzing everything, don't keep asking for more exams. So in conclusion, trying to incorporate the recommendations in real life and showing the difficulties that we cannot address in these recommendations and guidelines. Recommendations are essential, like this one in particular, to provide guidance. Of course they are. But in the real scenario, we need experienced clinicians and epileptologists to make the diagnosis. Although the treatment is complex, and hard, the diagnosis may not seem so easy. All methods, including video EEG, have limitations, and we have to check them. If you are not familiar with EEG and video EEG, and you receive an abnormal report, an EEG with abnormalities, and it does not fit in the scenario, even if it's possible to rediscuss that, do it. Because if you spend more time now, you avoid more exams, and to provide a positive feedback for functional seizures in these children. It's a complex situation, treatment and diagnosis. And just remember that although we create recommendations, nothing is useful if you use it in isolation. Thank you very much. And I will try to post this lecture later. Thank you. Thank you, Colin, for the invitation.
Thank you very much, Kette. That's a brilliant overview, and particularly thinking about neurophysiology and thinking about, you know, the complexity sometimes in terms of those diagnostic dilemmas. Our next speaker is Jay Salpekar. He's Director of Pediatric Neuropsychiatry at the Kennedy Krieger Institute and is Associate Professor of Psychiatry and Neurology at Johns Hopkins University Medical School. So he's a distinguished fellow, has distinguished fellow status at the American Epilepsy Society, the American Neuropsychiatric Association, and the American Academy of Child and Adolescent Psychiatry. I hope I got those right, Jay. And he's on multiple editorial boards and a long-time principal investigator for clinical research projects, particularly associated with psychiatric aspects of epilepsy. So over to you, Jay.
Thank you so much, Colin. Appreciate the introduction and the invitation. This is a great idea for a webinar, so I'm glad to participate and also hear from such expert colleagues as Kasia and Kette, as well as yourself, Colin. So thank you for that. Conflicts, as there, some past relationships, but no marketing activities. And I'll just start by going quickly. We've heard these terminologies before, and functional neurologic disorder seems to be where everyone has coalesced at this point. And that was reflected in the DSM also. And we do have this new category of functional neurological symptom disorder, which represents an advance and certainly a better understanding of what this might be. I'm very glad to not have the term psychogenic, although I think we all recognize the irony in calling something functional when it is not particularly functional. But it's certainly better than psychogenic. I'm not sure what that is or what it ever was, really. In terms of this FNSD, it is no longer necessary to have an identified psychological stressor, which differentiates it from conversion. So by and large, if we say functional seizures or dissociative seizures, I think most people worldwide will know what we're talking about, and non-epileptic events might be even more descriptive. Now, the problem is functional seizures and FNSD doesn't occur in isolation, and most of these children have at least something else going on. As many as 4/5 of them can have some other psychiatric diagnosis even. A lot of them have anxiety or depression. Notably, only maybe less than 10% have actual PTSD. And I think that tells us that this is a little bit of a different phenomenon in children than in adults, because we don't see the same types of histories or patterns, but we do have some clues, and that is a little bit of an anxiety sensitivity. When we heard before about Kasia talking about hyperarousal and a lot of her interventions having to reduce the sympathetic arousal, I think that's spot on. And I think that definitely gives us a big clue about what this illness may be in pediatrics, probably in adults as well. The other thing that we do know is that there are more somatization symptoms that seem to be present in this population as well. So more somatically focused, a greater tendency to have anxiety sensitivity, and to regard these internal somatic symptoms as dangerous. Now, we have to have some sense about the range of psychiatric illness that occurs in epilepsy, number one. Note that psychiatric illness is vastly overrepresented in epilepsy than in other chronic illness, even than in other chronic neurologic illness. So I think that's important to remember. And if we do have some sort of, if not epileptiform findings, but some sort of connectivity differences with non-epileptic events or with functional seizures, then that crosses even more boundaries into psychiatric illness in terms of pathophysiology, anxiety, depression, developmental disability. It's important to note that in autism spectrum disorder, as many as 30 to 40% of those children will have frank epilepsy. And then, of course, another percentage beyond that that may have epileptiform findings on an EEG. And it was also stated by my colleagues that even with acute stress reactions or ADHD or in the normal population, there might be EEG abnormalities that can be identified, even if they're not textbook spike and wave that describe a seizure. There might be something that is abnormal. So there's a wide range of psychiatric illness, but mainly we're really talking about anxiety. And if we're going to treat kids with functional seizures, anxiety is probably the way to go. Anxiety can be split up into different subtypes, generalized, social, or specific phobias. I think social anxiety is probably a better term to use now. And that's where anxiety symptoms, again, hyperarousal of some sort, panic symptoms, maybe feeling uneasy or unsettled, a sense of foreboding. And if it translates into more physical symptoms, insomnia, restlessness, irritability, then you're tending to be more generalized anxiety. If it happens in social situations primarily, then we might call it social anxiety. Panic disorder with or without agoraphobia, that's important to remember. Panic disorder or panic attacks escalate very quickly and crescendo, if you will, into an event. Not unlike functional seizures in a lot of ways, but keep in mind that there are various layers there. And then post-traumatic stress disorder. That's recently been sort of pulled out from anxiety because it's a little bit different. It sort of cuts into different types of functions like circadian rhythm, alertness, but the hyperarousal is the common thread there. Certainly there's overlap with depression and some nomenclature issues. We've talked about that already. So a lot of these children, now we know maybe they're having seizure-like events or functional seizures. My strategy is to try to look at what is peripheral to that. So if we say, okay, we know that you're having these events, these are functional seizures perhaps, or at least we have fairly strong suspicion based on all the data that we have from EEG, semiology, video EEG if possible. But then what else do we have? If we have somatic complaints, headaches, GI complaints, some other muscle pain or weakness or stiffness, then we might think a little bit more about a generalized anxiety. If we have irritability, then or real dysphoria or anhedonia, lack of enjoying any activities, then we might think more about depression. And irritability is probably the sine qua non for dysphoria in pediatrics. So a lot of children will not tell you that they're depressed. They might just be very irritable or unsettled, impatient, easily frustrated, cranky even. Those might be the ways to understand a mood state for a child, particularly if they are having this type of overlap with functional seizures. We still might see externalizing behavior or disruption. That's often part of depression. And then appetite, sleep, those are often altered. For older people with depression, sleep is usually decreased. For younger people, it's typically increased. Same with appetite. And then keep in mind that apathy, social isolation, substance usage, those might all be part of our clinical presentation. We've heard a pretty good description of antecedents to functional seizures. These can be enhanced or at least the threshold for these events occurring can be reduced. We're more likely to see them in the context of different stressors. I think, again, Dr. Kozlowska mentioned this hyperarousal. That's very key for this. Any type of stressor will increase your arousal, whether it's social and specific social situations, sometimes peer conflicts. It is not uncommon for a child or adolescent to have more frequent functional seizures in classes where there is a rival or a peer where there was a conflict before. Sometimes anticipation of seeing that peer later will lead to a functional seizure. Certainly, family stressors, unresolved stressors regarding illness, disruption, environmental. Maybe there's one class that's more difficult. And then ambient noise, whether it's a weather context or lights or sound. Sometimes these large environments with echoes or different flickering lights or loud noises, particularly if there's a cacophony in an athletic event or with a concert, that might lead to these events a lot more often. But more importantly for us is it could lead to diagnosis of anxiety or mood states in different situations that can give us a clue. So the way that I look at this, and I'll sum this up as quickly as I can, I think that treatment involves three different angles, and one is whether we want to have the neurologist involved or not, and I'll give more detail. And then individual with emphasis upon family involvement in psychotherapy or not, and then how to use medicines, symptomatic versus diagnostic. Now, this is an important review, and there's a lot of good information certainly in this review, but look at the highlighted section right below, which is that there is more evidence for the role of neurologists in both the assessment and management of FND. Now, this is so important to remember because, in fact, no one else can be as persuasive about the character of these events. If I have Dr. Kette Valente, who has just read the EEG and will say, I think this is a functional seizure, that carries a lot of power. It certainly carries a lot of power than having myself as a neuropsychiatrist or a nurse practitioner or a psychologist trying to give a diagnosis. So even if there's a regular check-in to verify and a sense that the patient will be treated and they're confident that they will be treated, I think that goes a long way to be therapeutic. In terms of therapy, this may be a challenge if insight is lacking. And a lot of people with functional seizures, remember, they're anxiety focused, they're somatically focused. They may not have a lexicon to describe anxiety. That's alexithymia, where they don't really have the tools or the vocabulary to explain how they're feeling. CBT and mindfulness may be very effective, a very directed strategy. I think that it might be effective, particularly for depression or for assisting with medication adherence and other types of cognitive disturbances too. We know that psychotherapy works, and there's a terrific study done by Tolchin, Barbara Dureski and company with Gaston, looking at adults referred for psychotherapy, and just know that with follow-up data, if there was some sort of treatment adherence, then they usually got better. The outcomes are actually very good for psychotherapy in this population. So just know that much. And also know that, in fact, if even if, I'll just boil this down, but yes, the outcomes are very good, but if the psychotherapy and the treatment starts right away, the outcomes are actually much better. People who are linked to counseling immediately, remember about the neurologist being involved, they are more likely to achieve remission even if they don't accept the diagnosis. And that's very important to note, that if the clinicians are on the same page, but the patients are not convinced, they can still improve. So let's think about medicines just a little bit. We're going to think about symptomatic treatments, and I think we've heard, some description of the alpha-2 agonists. Those are excellent strategies, very mild, but they can reduce the hyperarousal. You can accomplish the same thing with low-dose propranolol. Be careful about depression, though. An antihistamine, hydroxyzine, can be very helpful too. And then to treat sleep, you're not really treating the underlying anxiety or depression, perhaps, but a sleep medicine can be very effective as well. If you do have to use an antidepressant, usually the SSRIs are the best for pediatrics, although an SNRI, like duloxetine, can be very handy as well. Don't underestimate the benefits that anti-seizure medicines can offer us too. Valproate or lamotrigine are particularly good for mood stability, and they may help in the context of functional seizures as well as associated anxiety or depression. And then, of course, we have benzodiazepines, alprazolam, lorazepam, clobazam. They can be helpful not only in the moment, but in some cases they can be treatment for the underlying anxiety disorder. So interdisciplinary, certainly we're treating a lot of different things, but recognize that it's a multi-pronged approach. You can't usually do just one thing. We have to do a few things at the same time. In terms of psychotherapy, emphasize the therapeutic alliance, make environmental adjustments. Don't expose a child or adolescent, or adult for that matter, to an environment with a lot of noise or a lot of lights or a lot of activity or a lot of chaos. Those things all increase the arousal level, which can make it more likely for a functional seizure to occur. For pediatrics, we have US FDA indications for fluoxetine and escitalopram, and also sertraline and fluvoxamine. Just be very cautious with using those medicines. Be very patient, start at a low dose, and watch for activation, because the energy increases, but usually mood effects do not improve. Mood does not improve until several weeks after the energy improves. I'll skip over this real quick for the interest of time, but note that we can use a letter. We have to bring in schools to the process. I would request curriculum modifications on the other health impaired category if possible. This is a very interesting and strong statement by a patient who was in this textbook. We're going to have an update actually later this year, second edition of this textbook, but just know that that patients can often have very rich descriptions of non-epileptic events. There are other books that are also likewise, very useful. So anyway, I will say that epilepsy and functional neurologic symptom disorder may be prototypes for brain and behavior relationships. I think anxiety and epilepsy overlap particularly. Neurologists do need to be involved. They can go a long way to supporting the patient and be convincing, and I would use ASMs liberally. They may also be beneficial for mood stability, if not for a frank epileptiform illness. So I'll stop there and turn it back to you, Colin. Thank you.
Excellent, Jay. Thank you very much for that really good overview of the psychiatric aspects of functional seizures. Just to finish off the webinar, we have some questions. I think some of them have been addressed as part of the webinar, but there are maybe one or two, I think, which would be useful to discuss. And one of the questions we had was around the differential diagnosis of panic attacks and functional seizures. And again, we know in functional seizures, one may have symptoms of panic attacks. But would Kasia or Jay like to maybe comment on what you think about the differences between panic attacks and functional seizures, and how one would go about distinguishing those?
We actually, in my team, we often use a metaphor, particularly if there's a history of panic attacks in the family. We talk about panic attacks as being the sort of body arousal, but functional seizures includes the brain arousal, and families really get that. It's like we often say it's like a worse version of panic attacks, with both the arousal in the body and then the dysregulation, the neural network dysregulation in the brain. And if there's a family history of panic, everybody seems to get that sort of very, very easily. Yeah.
Jay, do you want to add anything to that?
Just that an EEG or video can be very helpful. Often context. Panic attacks usually occur in situations with very high stimuli or social pressure. Now that can still occur with a functional seizure as well, but sometimes functional seizures occur with a little bit more variability.
Another question we've had here, and I think it's an interesting one, and it said the question is basically, does placebo work? I suppose that's a very broad question, but in the context of functional seizures, I guess, does the panel have any views on that, Katie or Kasia or Jay?
I do. So we use positive suggestions all the time. I think positive suggestions are part of any good medical practice. So if you're using a medication, if you use positive suggestions about the medication, you're going to enhance the placebo effect of that medication. And I think it's the same with treating functional seizures. So, you know, our program has a name. People want to come into the program. They have the expectation that when they come into the program, they'll get better. So I think using positive expectations is a very powerful way to motivate people to then do the work, but also improve treatment outcomes.
Jay or Katie, have you any view on this?
I'll speak up. I think placebo can be very effective. I think it kind of it's hard to really have a placebo-controlled study as it is, because you're still interacting with people, you still get positive regard. There's a lot of contact you might have with an investigator, and we have very high placebo response rates in all of our certainly for treatments for clinical trials for depression. Oddly enough, we don't have so much placebo response. There is some, but much less for stimulant medicines for ADHD, for example. So I think it does vary, but I think that anytime we talk to a patient with functional seizures, with, you know, regardless of what the condition is, we tell them that we have to have a positive outlook, that we have to do other types of things that will enhance their wellness. And I think, you know, whether that's placebo or not, perhaps it's related, but I think placebo can be very effective.
Katie, do you have anything to say on this topic? Do you want to add anything, Katie?
Oh, as a treatment, yes, but as a confirmatory thing during PDEG, we have to be careful. In our recommendations, we mention specifically not to use provocative techniques. And then what's frequently done is to use provocative techniques, and then you confirm that's not an epileptic seizure using a placebo and say to the patient that is a medication that will stop his or her seizures. This is unethical from our part. We have to be careful. And also with provocative techniques, we may have events that do not represent the events that they have at home, since they are under a very stressful situation. And it's very common to have, for example, panic attacks with provocative techniques, and we're just adding more layers to this complicated diagnosis, complicating the treatment.
Thank you, Katie, and thanks for pointing that out in relation to assessment. So we're coming to the end of our webinar. As I've said earlier, the recording will be available on YouTube in a short period of time. So I thank you very much, everybody. There is a QR code at the end of the webinar, and we would really love your feedback on that. So thank you very much for your attention today. Take care. Bye-bye.